Okay, chapter 9. This is pain management during labor and birth. Now, you know that labor is called labor because it's difficult and it's hard and it's extremely painful and really difficult for the moms. So let's kind of look at some things that we can do to help those moms get through this labor process. Well, as far as labor and pain, it is associated with a normal physiological process. So it is normal for moms to go through the pain and the delivery and all of that because it is unique in that fact that there is something going to be at the end. But it really increases in intensity as that birth approaches. So a lot of moms will begin that labor process and it won't be too bad, but as it progresses and the further it gets, the more difficult it's going to be. So you can see why in that latent phase, they're happy, everything's going good. Then they get into the active phase and it's like, oh, this isn't so much fun anymore. And they get to transition and all heck breaks loose. And it's the most difficult part because as we progress through that labor process, it's going to get much, much, much more difficult. But the only good thing about pain here is we know that this is predictable. We know what's going to happen. So if we know what's going to happen, we can treat it accordingly and help those moms get through that birthing process. So first stage of labor, we've kind of talked about what our contractions are doing. They're stretching and thinning out that cervix. And they're going to have lots and lots of abdominal pain. So that's going to be mainly stomach pain, that first stage of labor. So all three, the latent, the active, and the transition, those contractions are all doing something with the cervix. And they're all doing something with, getting that cervix ready to go. So the pain's going to be more abdominal. During that second stage of labor, the pain's going to come from stretching of all those tissues. As that baby's flowing through that canal, the mom's going to feel that burning, that stinging sensation in the perineum as that baby's coming through. It's going to have tons and tons of pressure. It's going to feel more pressure and stretching and stinging and burning. Now, things that are going to kind of influence mom's pain, there's a few things that can happen. What is mom's threshold? What is her tolerance to pain? Sometimes we know people have a very high pain tolerance and they can tolerate a lot of pain. Other people don't have a very high pain tolerance, so any little bit of pain is going to be difficult for them to handle. Age and parity. How old are they? If they're 16, they don't have a lot of experience with pain, so they're not going to really know what to expect. And parity, if they've done it before. If this mom has been in labor before, this is not going to be her first time to do this. She knows how difficult it's going to be. She knows that pain feeling. Anxiety levels. This is kind of goes back to our psyche, in our 4 Ps. If mom is super anxious, it's going to be more difficult to get that baby out. And culture. Depending on what their culture is, we can't stress culture enough because we do see a lot of people coming in with multiple different cultures. And it's very important that we become culturally competent with our patients. So if you've been able to spend a lot of time with your patient, you will be able to understand their culture. And if you don't, ask their significant other, ask the patient, what do you need and what do you want done? And that way that nurse can be culturally competent and go ahead and do those things for her without her having to ask when it gets further and further into their labor process. And what is mom's physical condition going into labor? If mom has been very active and exercise and she's been doing a lot of things, labor may be a little bit easier for her than somebody who's been very sedentary, somebody who has not been physically conditioned to go into labor, because it's going to be very difficult. The length, size, and position of that baby, that's going to make a difference in how much pain mom's going to have. How big is baby? What position is it in? Remember when we talked about if baby comes out occipital posterior? That's going to increase mom's back pain. It's going to increase the time that she's going to be in labor. So, and then was mom induced, or did mom go on into labor on her own? It is, studies have shown that moms that go into labor on their own with their own oxytocin do way better than when we induce them and we give them synthetic oxytocin. It makes labor longer. It makes the contractions a lot harder and a little bit more difficult to manage on their own. And then if they've had a dysfunctional labor, which we'll get to those a little bit later on, talking about dysfunctional labors. So pain management, we're kind of going to think about all the different kind of ways pain management can be done, but there's really not a perfect way. It basically depends on mom and how we need to control labor and what mom's birthing plan says. What did mom want during her birthing process? Does mom want to have a natural birth? Does mom want to have an epidural? Does she want nitrous oxide? What does she want? So all that needs to be planned in advance and needs to be implemented. Now, can mom change her mind? Absolutely. If you get a mom and they say, I don't want an epidural, she gets 6 centimeters and says, no, I can't take it, I want an epidural. We can certainly put an epidural in. We can do those things, but it's important to know it up front so we can help them manage it if they still want to continue with that natural birth. So we got to look at the safety of the mom, what kind of pain reliefs have worked with her in the past, what things have not worked for her, if she's had a baby before, what things were better for her than other things. So there's 2 types of categories that we're going to kind of look at, non-pharmacological and pharmacological interventions. So we're going to look at non-pharmacological first. So this is just basically labor support. Get in there, help those moms, help them with their breathing, comfort measures. That's going to be lots of pillows, supportive devices, the peanut ball, the bouncy balls, putting them in different positions, having them stand, having them walk, having them squat, having them sit in like Indian style to help bring that baby down. Imagery, imagery is a big one. We're talking them through, okay, visualize yourself being someplace else. Effleurage is a big one. So if you think about effleurage, that's just basically where someone takes their hands. It's part of the gate control method. We think that if we can stimulate other types of nerve endings, we can block those pain responses to the brain, and that will help prevent some of their pain. But effleurage is where they take their hands and they just go up the belly and around the sides of the belly, up the belly and around the sides of the belly. It's very, just using the fingertips, and they do that on the belly, and some women say that that can help with their pain. And so we can do that. Breathing techniques, make sure that a lot of times we're in there about every 15, 20 minutes, and we turn, we reposition, we massage their backs. Hydrotherapy is one where we can put them in the bathtub. So if they feel better in the bathtub and they can be more relaxed, put them in a warm bathtub, let them sit in the bathtub and help with some of that. Hypnosis is one of them. Intradermal water injections, where it's just sterile water that we inject into the skin, and that also goes along with that gate control theory, that if we can block those pain responses, then those little pain responses that they're feeling will block out those big pain responses. Acupuncture, acupressure, all of those things have been felt to improve some of mom's pain. But if that doesn't work, we're going to move on to the pharmacological interventions. So interventions that we can do here, these are going to be analgesia. And so what analgesia does, just reduces the sensation of pain. And then sedation. Sedation is just a state of decreased anxiety, decreased stress. It promotes relaxation. So sometimes moms, if they get really, really highly anxious in that active phase of labor, in that first stage, but the active phase, sometimes we can give them some sedation. And sometimes that will help them to relax a little bit and allow the body to kind of do what it is naturally supposed to be doing. We can give barbiturates to sleep if they're having difficulty sleeping and they're in that very early stage, that latent stage. We can give them something to kind of help their bodies relax. As far as opioids, these are going to increase their ability to be able to cope with labor. However, we do see those adverse effects. They do cross the placenta barrier, so they're going to go exactly to baby. So again, during that transition stage with mom would not be able to get any opioids just because it's going to decrease their respiratory system. It's also going to decrease baby's respiratory system and make it more difficult for baby. So thinking about what types of things that we can do. One, we can do opioids. That would be like Demerol or Meperidine. That would be like Buprenorphine, which is Stadol. It might be nalbuphine, which is Nubain. You guys will need to know them by those generic names. So you would have to know them by meperidine, butyforinol, and nebufine. These are kind of hard. I know they're kind of hard words. I know them a lot better by their brand name. But we would use those for pain relief. But they do cause respiratory depression. So if they're causing respiratory depression, we've got to look at mom and we've got to think about the baby. So if you get a mom and her, her respirations get down too low and she's not getting enough oxygen in, neither is baby. So at this point, we might want to put oxygen on mom, reposition mom, decrease the amount of opioids that we're giving to mom, just to make sure our babies are getting what they need. Pain relievers, such as like Toradol, which is ketoretic, we can give that IV. A lot of times we give that right after surgery. It is an NSAID. So it does help with inflammation and decreases some of that inflammation. Motrin, we can give Motrin. Usually, sometimes we give this after delivery though. Tylenol, if mom's in labor and she's got a headache, we can try some Tylenol. Norco, we usually give that after delivery. And Percocets. So these guys are usually after delivery. This is what we're going to use usually during delivery for that type of pain. Now, as far as anesthesia, analgesics, what analgesics are going to do, which we talked about right up here, analgesics just decrease pain sensation. That's like your Tylenols. Now we're going into our anesthesia. Anesthesia is different. This is where it's going to partially or totally block a sensation or an area to their body. It's going to block it. We can have a regional anesthesia. Regional anesthesias are going to block a region of the body. So we get something called a pudendal block. A pudendal block, sometimes we used to use these. I think some of the physicians still do if moms want a natural delivery. They go up into the cervical, through the vaginal area, into the cervical area, and they give them a pudendal block. And what that does is it blocks that pain as the baby's coming through that birth canal. It doesn't take everything away. It does not do a whole lot for the contraction pain, but it does help with that burning, and it does help with that pressure sensation. They can also get an epidural, which most of our moms opt for those epidurals. This is an intrathecal injection that goes in. The biggest complication with our epidurals, it's a catheter that goes in and it stays in that intrathecal space until we're done with the catheter, and then we pull everything out. However, biggest complication that we see with epidurals is hypotension. These moms, a lot of times we want to make sure we have a good IV going. And recently I think they have started making sure that moms have 2 IV access because of hemorrhage and because of maybe needing to give them certain types of drugs. So hypotension's a big one. We got to make sure we have a working IV. We got to make sure that we have oxygen ready to go, because if mom gets hypotensive, mom is not pushing blood to baby. There's no blood going to baby. Baby's also hypoxic. So we're going to make sure that mom gets oxygen if she needs it. We're going to give, a lot of times we'll give a fluid bolus to increase the vascular space, just so they don't get that hypotension. The other problem that we can get is total spinal blockage, and where it moves up a little bit too high and probably can cause complications with the respiratory system. So we got to watch for those. Sometimes those moms, if they're given in the wrong spot, they might end up with, intubation. Spinal headaches, that's a big one. If it gets in the wrong space, you can get a spinal headache and it will leak and it causes severe pain in the head. Sometimes these moms have to lay flat for 6 to 8 hours afterwards to prevent that from leaking. Sometimes they will actually go in and take a little bit of blood from mom, and they'll go in and do a blood patch if that spinal headache is super bad. And some of the medications, and I think it's some of the opioids, cause really bad pruritus, which is itching. And those moms will itch after delivery. So sometimes we'll have to give an antihistamine or something for that itching. And they can get urinary retention just from the analgesia. Sometimes just the medications that we during the epidural can cause urinary retention. So we want to make sure that we're looking for that too. Okay, so here's where your, let me move my face. This is where it's going to go in. They're going to clean the back really good. It's going to go in the lower thoracic. So they're going to go in, and it depends on which one they're doing. They're doing an epidural or they're doing a spinal. So, and I don't know that I've gotten to a spinal. If I don't, I will talk about the spinals. Yeah. So the next thing we'll talk about, we've talked about the epidural. So we're going to talk about another regional anesthesia that we can do, and that's a spinal anesthesia. We call it a spinal block. Now, that's different than an epidural. An epidural goes into that dural space. It doesn't completely get rid of all sensation. Some moms it does. Some moms say they can't feel anything when they get the epidural. Other moms are able to move their legs. They can feel some of the pressure. They can feel some of the tightness, but it is way better than without the epidural. A regional anesthesia or a spinal block completely blocks all feeling from about the top of the abdomen all the way down to their toes. It's a complete block. We do spinal anesthesia more for moms that come in that are getting C-sections. So we give them a spinal anesthetic, and what that one is, they give the anesthetic into the spine and there's no catheter. It comes back out and we don't have anything in there. The epidurals have the catheter that remains. The regional anesthetics do not. Again, this is where those spinal headaches can come into play. So, they might have to lay flat. So as far as general anesthetic, we rarely ever do general anesthetic because we use the epidurals the most. General anesthetic, if they have any history of malignant hyperthermia or malignant hypertension, that would be a contraindication not to do general anesthetic. So just remember, these are your problems that happen. The same problems that happen with epidurals, the same things, the hypotension, all that is the same thing that's going to happen with your spinals. So a lot of the complications are very similar with your spinal anesthetics. Okay, that is the end of our pain chapter.